Page. So, good afternoon, everyone. So, today I'll be dealing with the respiratory symptoms in palliative care. Okay. We'll be discussing about two topics today in detail about breathlessness and cough. Okay. So, starting with breathlessness, the prevalence of breathlessness in palliative care. Usually, we see a lot of patients with breathlessness, and about 75 to 87 percentage of the patients they'll be having lung cancers. But it should not be forgotten that those patients with advanced malignancies, AIDS, heart diseases, COPD, and other renal diseases also present with breathlessness. They will be having breathlessness as an end stage disease. So in such cases, when none of the other medicines work, we have to deal with them. And so we deal with that also. So starting with the definition, the American Thoracic Society defines dyspnea as a subjective experience of breathing discomfort that consists of qualitatively distinct sensation that vary in intensity. For each patient, it will be a different sensation. That is what they are saying. It's a subjective experience of breathing discomfort. We'll come into it more. So it is one of the distressing symptoms we usually see come across here. Because I say this because we see a lot of pain patients, those patients with intractable nausea, vomiting, all kinds of other symptoms. But to some extent, we'll be able to see their relief when we give some medications. They improve like little fast. But that is not in the case of breathlessness. We have to wait. We have to be calm. It takes little time also. It also causes psychosocial distress for patient and their family. Can you imagine your loved ones gasping for air like this and seeing this continuously? How do you feel? Will it cause a psychosocial distress for them? Will it cause an emotional impact on their minds? Yes, it is causing a psychosocial distress for both family and all for the patient also. Since because the underlying etiology is progressive, we also find it as professionals like sisters and like doctors, we also find it difficult to manage breathlessness. So how does the patient describe it? So most of them will be telling like air hunger, work or effort, tightness. What is that? Air hunger. Some patients will be telling like, doctor, I cannot get enough air. My breaths are not satisfying me. I'm starving for air. Patients tell like that. And some describe it as an effort or like it's an effort to breathe. I have to work more for getting a breath. And sometimes they describe it as tightness. How come tightness? Sometimes bronchoconstriction, bronchospasm. They give a feeling that there is a tightness in the chest. So it depends on the patient, like how they feel. That is a thing. Now, coming to the causes. What are the primary diseases or the primary causes of breathlessness? Most of the time, it will be lung malignancies. Otherwise, it will be metastasis to the lungs. Those other malignancies causing lung mets can cause breathlessness. Otherwise, it could be lymphatic infiltration by tumor into the lungs causing distress. It could be malignant pleural effusion, massive pleural effusion, restricting the recoiling and coiling property of the lung, which can cause breathlessness. Tracheobronchial obstruction. How can that happen? This mass, the tumor mass, may obstruct the bigger airways. In such cases, tracheostomy will not help sometimes. So in such cases, that obstruction causing the obstructing the passage of airflow can also cause breathlessness. The other thing is treatments like surgery, radiation, chemotherapy. All these things can cause fibrosis of lungs and, in fact, breathlessness. So, what other causes? Other causes include cardiac, like cardiac causes are cardiac failure, patient having pulmonary edema, patients having angina, arrhythmia, myocardial infarctions, and other pulmonary causes like infection, COPD, pneumothorax, pleural effusion, pulmonary embolism. All these can contribute to breathlessness. These are managed in a different pattern in other hospitals, but like when there is no treatment, like when everything has tried and everything is exhausted, but still the patient is having, when the patient is having breathlessness, we can manage it here. So, how can cancer cause the breathlessness? The lung cancer itself, like I said before, the mass or the tumor can obstruct the air passage and it can cause breathing difficulty. Ascites in patients with liver malignancies, they will be having, like CLD, patients having CLD can have ascites. The massive abdominal distension will cause a thrust on the diaphragm, and it in fact obstruct the normal air entry, and it can cause difficulties. Other thing is cachexia causing respiratory muscle weakness. And another thing is cancer microembola in the lung, and which can cause pulmonary embolism, and then the pleural effusion. It causes the tumor might cause irritation in the pleural membrane, and it can cause pleural effusion. Now, coming to the psychological cause, this is very important here. This is very important because we have a part in the management. We have to closely look into this matter, the anxiety, panic attacks, and depression. What does it cause? When we talk with patients who are having breathlessness, like 90% of the patients will be having a fear of dying when we talk to them, and when we speak to them later, we have understood that this dyspnea, this breathing discomfort, when the patient is having such a discomfort, most of them will be having a fear of dying. They'll think that this is going to be their end and they'll die soon, which in fact increases their anxiety and thereby increases the dyspnea. So, this is very important, the dyspnea, fear of cycle, and increased anxiety cycle. So we have to address this during our treatment. I'll discuss about it later, but you have to keep this in mind also. Not only the physical factors, but this is also posing a this is also very important. Now we can start assessing the patient. Now we have learned about the different causes of breathlessness, what and all can cause breathlessness. Now we are going to do the assessment. How we are going to assess this patient? We have to take a detailed history. We have to examine the patient. So about the detailed history, we have to ask about the onset, like how did it begin? When did it begin? What is the duration? How frequently does it occur? Palliative or provocating factor. What makes it better or worse? Quality. Can he or she describe the feeling? Related symptoms like any other symptoms, cough. Sometimes, most of the time, all these breathlessness will be associated with intractable cough also. Like we said, anxiety, isolation, severity in the scale of 10. We have to ask like how is breathlessness out of a score of 10? Like we ask for pain. Any treatments taken for it, and how did it respond when you took that treatment? How was it? Did it give any relief? You have to detail. You have to record everything in detail. Now, coming to the physical examination, we are going to examine the patient. We have to take the vitals. We have to take the respiratory rate. We have to count it for 60 seconds. We have to count the respiratory rate at least for 60 seconds. We have to record the saturation using a pulse oximeter. And coming to the general physical examination, we have to rule out, we have to look for central cyanosis, that is a bluish tinge in the tongue and oral mucous membrane. And all the other things, in physical examination, we have to look for the position of the patient. Most of the time, patients having breathlessness, they will be comfortable in a propped up position, in a Fowler's position. That is 45 degree from the bed. So it is not like it should be like that. Most of the patient takes their own comfortable position. So mostly it will be in a propped up position. Then there will be active accessory muscle usage, nasal flaring, there will be mouth breathing. I'll show that. This is a cancer cachexia. Accessory muscles. In cancer cachexia, all these accessory muscles of chest wall will also degenerate, which in turn will cause breathing difficulties. Then you can see nasal flaring in these patients. Then, yeah. So then we have to do all other things, a palpation, we have to percuss, we have to look for pleural effusion, we have to rule out whether it is a pleural effusion or it is a solid mass, whether it is a consolidation, like that we have to rule out. Then we have to auscultate the patient, look for all the heart sounds, whether it is vesicular breathing and all. I'm not going to detail because it is not that important in your this thing. We have to look for all the other things. Now, coming to the management part. This part is actually very important. We are going to start our treatment. We have understood so many things that the patient is having all these kinds of difficulties. He's finding it very hard to breathe, and that could be because of the pulmonary edema, and that could be because of the pleural effusion. We have understood everything. These are the usual things we do everywhere in hospital. Now I'm coming to the management part, which is little different from what we practice in the usual daily life. If you see a patient in an OPD complaining about breathlessness, and we are suspecting a pleural effusion for them, we'll definitely write an X-ray for them. We'll advise an X-ray. And if we find that the patient is having pallor, we'll definitely give an investigation to do all the complete, come on, do all the complete blood counts. But here, we have to think twice. Before writing or before advising an investigation for such people, for those patients whose prognosis is very bad, you have to think twice. We have to always think whether it is going to alter the line of management. A patient having chronic breathlessness coming to you, complaining about breathing difficulty, you can't write a X-ray like that. You have to think whether this will help. Whether taking an X-ray in this situation, will it help? You're seeing a patient in home care and you're seeing this. Will you tell them, no, no, you have to take him now, right now to hospital and you have to do the X-ray now? We should think. Definitely, we should do an X-ray if there is something correctable. If we find that if the patient is having any correctable measures. But that is not in the case of patients whose prognosis are very bad. And if we think that it is not going to alter the line of any management. So always think about it. You can, it is not like you should not, but you have to be more cautious. Okay. Now we are starting the treatment. I like to talk about, and I like to tell you an example. A patient is coming to you at the middle of the night and he is breathless. He's severe breathless. He's having severe breathlessness. And you assessed him, you took the history, you made all the assessments and all. And you found that he needs to be admitted in an ICU. He is in his terminal state. He is having his last days of life, will you take him to an ICU? Did you talk to him about it? No. In usual setting, we never discuss with the patient about this, whether they need to be taken to an ICU or not. You should always think about this from now. You should ask the wish of the patient. You should understand that that will be his last days of life. He might wish to live with his family. He might wish to spend the last days of life with his family. So always remember this. Talk with the patient. Discuss with your care plan with him also. And another important thing during that time is you have to communicate. Communication is very important at this stage. Whenever such a patient is brought to you, you have to explain all these things, all the inconvenience and risk of investigation. What will happen if we do some certain things? What we do if this thing happens, and what if not? All things have to be discussed in the initial setting itself. And next, the benefits of treatment, like what you are going to do, will it help him or will it not help him? The life expectancy of the patient. Start treatment after this. The decision making should be done with both the patient and family. We have to work as a team before deciding something. Most of the patient, when we ask like whether they want to be in ICU, most of them's reply will be no. They'll be telling us, I know that for those patients who know their prognosis, they'll always tell they want to be with their family. They want to spend the last days with their family. So, isolating them from their family to an ICU setup will increase only their emotional trauma. It will increase the anxiety. So, always keep this in mind. Now, this is the step of our treatment. Correct the correctable, non pharmacological, and pharmacological methods. What is correct the correctable? Sometimes in patients who are coming to you with severe breathlessness, we have to look for correctable factors. Sometimes it will be a respiratory infection. It may subside if we give an antibacterial. Sometimes it may be a pleural effusion where thoracocentesis can be done and it can relieve his breathlessness. Ascites, we can do paracentesis and diuretics. For anemia, we can give blood transfusion. For heart failures, we can give diuretics and AC inhibitors. All these things we have to keep it in our mind. It is not like a patient coming to you in palliative care and you should not say like nothing can be done. Correct the correctable things that we can do. Identify it. That is in our part. Okay. It is not like we cannot do thoracosynthesis in a patient who is getting palliative care. He can do. Because what if it helps in pleural effusion patients? Even if we give so many drugs also, if the pleural tapping is done for him, it will give him better relief. So we should not forget that. We should always correct the correctables initially. We have to look for correctable factors. Now, this is the second thing. This is what I told earlier, that we have to address their anxiety. The psychological factor, the anxiety, will increase their dyspnea. So it will be always nice to tell him or her that one of us is going to be here until your breathlessness has reduced. I know it is very difficult in a busy setting to tell a patient who is having breathlessness and to calm them. We are saying that one of us will be there. But you know how much relief he'll be having after hearing this. That is very important. The calm presence of healthcare team conveying empathy will relieve their anxiety. The urge to take that breath, that will reduce. Talk with them. They'll have fear that whether they will be taken to some other place, whether they'll be shifted to an ICU. They'll be thinking about everything, even during the time of their distress. So, in that non pharmacological methods, you have to do this first. Next is what are non pharmacological management? Hope you will be knowing it. Those things we can do without, like, before starting any drugs. These are the things we have to keep in mind. Okay. So next is loosening the patient's cloth. It will give them that some kind of tightness will be reduced. Then using a table fan to maintain air circulation. Keep room windows open. Increase that will increase the perception of space. And next is a comfortable position of the patient. That is also important. That's what I told, like I said earlier, that most of the patient will feel more comfortable. They feel more comfort when they are in proper position. But that will not be in the case of everyone. So you have to ask them, like, in which position are you comfortable? And we have to try and keep them in a proper position. If they are comfortable in that position, you can keep it like that. But it will not be same for every patient. So that's why I have put in like that. You have to keep them in comfortable position. And you can also try modified breathing techniques like pursed lip breathing, diaphragmatic breathing also. So we have to try for all this non-pharmacological management. So starting just revising, starting our treatment, we'll ask the wish of the patient. We'll communicate with the family. Decision will be made then. Then we'll look for all the any correctable factors like infection, effusion, anything like that. And then we try for all the non-pharmacological management techniques. And next comes our pharmacological management. Like we do in usual practice, we give bronchodilators, short-acting and long-acting bronchodilators with oxybate supplementation. And the next important thing is corticosteroids. How will corticosteroids help? Here, a patient having a tumor mass in the lungs, it is causing a tracheobronchial obstruction. How will this corticosteroids help? Answer is, it decreases the peri-tumor edema around the tumor. All tumors inside our body, even if it is abdomen, even if it is in the elementary canal, everywhere, every tumor causes a peri-tumor edema. So when we give this corticosteroid, it will reduce the peri-tumor edema. So in the case of lungs, when when you give corticosteroids and when this peri-tumor reduces, even a small increase in the diameter of the alveoli, when this when the edema reduces, there will be a small increase in the diameter of alveoli. It brings a great relief for the patients. So corticosteroids like dexamethasone will help. Corticosteroids like dexamethasone, when it is given in an OD, 8 to 16 milligrams per day for 3 to 4 days, it can reduce the peri-tumor edema. So, next comes the wonder drug, morphine. You have heard the name of morphine for pain management, is it? So, morphine not only helps in pain management, but also helps in breathlessness management. How is that? Morphine in lower doses acts on the respiratory center. As we all know that morphine will cause a respiratory apnea, but in lower doses, it acts on the respiratory center and it slows down the respiratory rate. That's how it works. A question always comes like how morphine helps in management of breathlessness. So this is the answer. In lower doses, it acts on the respiratory center and it slows down the respiratory rate. So it also reduces the inappropriate and excessive respiratory drive. And the breathing is made more efficient and sensation of breathlessness will also reduce. And that is how it works. So usually for pain management, we give doses. We give starting doses like 5 mg Q4 Tali or 5 mg Q6 Tali. But here, in the management of breathlessness, we give only lower dose. That will start with either 2.5 mg. 2.5 mg morphine, we give it as VD, or we give it as TDS, or we give it as Q6 Tali. And how it acts means it slow down the respiratory rate and it reduces the inappropriate and excessive respiratory drive. And the patient feels so much relief when the effort is reduced. They feel like little more better. This is not only in the case of lung malignancy, but in the case of COPD, when the patient is having severe breathlessness at their end stage. Patient having cardiac failures who are having breathlessness, not responding to diuretics, when nothing works, we can use morphine. So the dose can be hiked up to 5 milligram, and it is according to the distress. So that is all. This is also very important. Opioid dose required for breathlessness is usually less than that required for pain management. Sorry. Sorry, there was a technical issue. Okay, we'll continue. Next slide. Next slide. We have already discussed this. Next slide. Okay, just no. Up. Up. Okay. Now, I need to discuss with you about a very important thing about the oxygen. Oxygen also plays a very important role in the breathlessness management. Most of the time, patients in ICU, those sick patients, they will be in oxygen support. So it is a very difficult situation to wean off them from oxygen, and mostly it will be the only reason why patient is not taken to their homes. Like patient will be forced to continue in hospital because they need a oxygen support. So here, when a patient is having breathlessness, who is having a lung malignancy, comes with a severe breathlessness, will oxygen help? We have to think about it. Sometimes those patients who are having a tumor mass obstructing a big tracheobronchial tree, causing obstruction, patient is having breathlessness. And most of the time, the patient will be having low saturation. In such cases, will there be any use of giving an oxygen? Sometimes it will be no. But it will be difficult for you to communicate that to the caregiver. They'll always ask, doctor, can we give him oxygen? Can we put him on oxygen? What will you tell? You can tell them, yes, we can give a trial. we can give a trial of oxygen and see whether it will help him or her. So we'll start oxygen, and it will only take 7 minutes for the oxygen equilibrium to attain. And if the patient is having any relief, we can continue that. But most of the time, it will not be. Most of the time, patient will be still in distress. What is the point in increasing the saturation from 81 to 87 without having any improvement? It will only cause a distress to the patient. Presence of a face mask, it will cause a sense of suffocation for them. They'll not be able to communicate with their family members. Already their sounds will be low. In addition to that, if you keep a mask like this, they won't be able to communicate properly. So, also, there will be drying up of the tracts, which causes more distress to the patients. So, what we can do here is we can give an oxygen trial. We can give oxygen for 10 minutes. We will see that is helping the patient. If the patient is having any relief with that, if not, you have to communicate with the family regarding this. You have to explain them that it is not helping him. One more thing about the pulse oximeter. We always connect a pulse oximeter when a patient with breathlessness comes. Everybody will be on that, whether his saturation is improving or saturation is he desaturating. Everybody will forget the patient. You should not do that. When you have sisters and doctors in your family, they'll be more worried about that only. Everybody will be keeping their eye on the pulse oximeter. That should not happen. You have to see whether it is giving any relief for the patient. If not, communicate with the family about this. But it is not easy, as I tell like this. We find lot of difficulties to communicate, to make them understand that it is not helping them. In certain cases, we can't do anything. We'll have to continue it, but still we have to make them understand about this. That is called as a trial of oxygen. Instead of using a face mask, you can give nasal cannulas also. If it is helping, if oxygen is helping, you can give nasal cannulas also. So you should be aware of all these things. You should think about this when a patient comes with it like that. Okay, next slide. So that was all about breathlessness. That was our main topic. So cough is very similar to cough management, and cough thing is also very similar to breathlessness. So I'll just run through cough. Prevalence of cough is in cancer patients and in COPD patients. Patients may also experience psychological impact, social embarrassments, continuous coughing. Our family will self isolate us from others. They will feel separated. Some patients who are having chronic cough, they will be suspected to have TB. People think that they have some other diseases. They will be kept in isolation. So what are the causes of cough in palliative care? It's mostly it is tumors. Tumors are more likely to cause cough with involvement of airways than lung parenchyma. Cancer involvement of pleura, pericardium, mediastinum, pulmonary lymphatics, blood vessels may cause cough. Aspiration present with cough on feeding or at night, aspiration pneumonitis or pneumonia can cause. Conditions with hypersecretion of mucus are also associated. These are the common causes of cough. Most of the time it will be associated with breathlessness also. Okay. So what are the complications of having a chronic cough? Cough can cause physical complications like chest wall pain, continuous coughing. It can cause chest wall pain, fracture of ribs, continuous coughing. Patient might, they can have urinary incontinence due to the pressure, sweating, exhaustion, and disturbance of sleep. So assessment is same as that of breathlessness. We have to take a detailed history. We have to assess the physical examination. Everything can be done. and we can we can give a radiotherapy or chemotherapy. Treatment may palliate cough due to tumors. Sometimes these tumors may cause irritation in the airway tract, and that it can cause. The irritant can itself cause cough. So sometimes by giving a radiotherapy, which will decrease the size of the tumor, may relieve it. That's what. Steroids may be useful in reducing tumor-related edema and airway obstruction. Like we told, it may decreases the peritumor edema, which decreases the irritation in the airway, and that can also like help in reducing the cough. Like we said before, underlying infections, we have to correct the correctables here also. We can try for looking for any correctable factors, and we can try correcting it. Next slide. And cough suppression, now coming to antitussives, like cough suppression aims at symptomatic treatment in cases of dry cough and disturbing cough. Antitussives can be given. We can try all the other things. If nothing works, we'll go for opioids again. Lower dose of opioids help in relieving cough. Since it is centrally acting, it centrally acts on the respiratory center and reduces the cough threat. Next. It is also very similar like how we manage breathlessness. We start with lower doses only, like 2.5 mg BD or 2.5 mg TDS, and we look for the this thing. We can also give demulcents like soothing substances like glycerol, protussives, making cough more effective and less distressing, like mucolytics, like ambroxol, bromhexin, etc. So cough is very similar to cough management is also very similar to breathlessness. So that's all. Thank you. So the main things is like the new things which I have told, like about the oxygen trial we can give, like mm, what like talking with the patient, discussing with the patient regarding their wish, whether to take them to ICU or like to allowing them to continue with their family members during their last days. So that's all about this thing. Have any doubts? Can ask.
Thank you, Dr. Nayana, for the wonderful presentation. So, anybody have any doubts on this? Please ask it. Anybody? No, I think no doubts. Your presentation is clear to everyone. So before moving on to the case presentation, I would like to highlight few things about breathlessness. Madam was discussed very well, but even then I would like to highlight few things because we have seen many patients with breathlessness. We have to do the proper assessment because we need to identify the cause. And most of the time, the person who is in breathlessness, they will be anxious. So they will not be able to take adequate deep breath. So instead of that, they'll take a short breath. So that air not entering into the lungs too. So because they will be anxious and they will be thinking like they will be dying soon. So the in between, if you listen their distress or you were there to observe their problems, they will be asking like, "Am I die soon?" So these kind of questions will be there. So what you have to think is you have to keep it in mind is if they have an anxious, definitely the breathing difficulty will increase and they will not be take adequate breath also. So, if possible, try to manage with a non-pharmacological measures, because uh, as ma'am was discussed earlier, be with the patient and tell them that, so we are here to uh, to relieve your stress. But that kind of reassurance to the family also, not only for the patients, the family also worried about that. Family become distressed, and so they all will be in the distress situation. So that time, you have one of you can talk to the patient, and one of you can reassurance, give talk to the caregivers, and the reassurance is also important in that stage. So the another important thing is oxygen. It's very, very important. Um, if possible, you can use nasal probes, but you can do a trial. So after 10 minutes, you have to talk to the patient and ask the patient that oxygen is beneficial or not. So if the oxygen is beneficial, then you can continue. Otherwise, you have to talk to the patient caregivers and make them understand, and uh, try to do the needful, because this is also very, very important. And maximum avoid the oxygen, that mask. Try to give with nasal probes. So these are the important that things I would like to highlight, and the other pharmacological management and all things Madam was discussed clearly. So can we move on to the case presentation, ma'am?
Yes, yes, we can.
Okay, Sister Hema will be presenting a patient story. Hema, sorry.
Shall we start?
Yes, ma'am.
Yes, we can start.
Very happy good evening, everyone. I'm Hemwat Narayagi, nursing officer from AIMS Mangalagiri. First of all, I would like to thank everyone, especially the parliaments like facilitators, for giving me this opportunity to present in front of you. And today, this is a patient story. Let's move on to the topic. Patient details: 74 years old female, got admitted in our hospital. Diagnosis was cholangiocarcinoma with lung metastasis. Do you want me to share the screen?
No, ma'am.
Okay. On July 23, patient got admitted in emergency department with the following complaints. Patient had dyspnea on admission. She had altered behavior and pain abdomen, generalized weakness, projectile bilious vomiting. Uh, since May, patient previously she wasn't on any other medication. She don't have any comorbidities. On May 2023, patient was presented with the complaints of cough with expectoration. It was like for 2 months, and she got she came to the OPD with those things, and that wasn't settled by bronchodilators and cough suppressants. And after the investigation, she underwent chest X-ray, then CCT, thorax and abdomen. Then it was confirmed as cholangiocarcinoma with lung metastasis. On the very first day of she came with the complaints on the very first day. These investigations happen, and they explain her this is the scenario, and her condition was explained to the patient attender. Her son wasn't very ready for opting any other treatment, because as they said, like it is a cholangiocarcinoma. They already had like diagnosis in a very last stage, and it got metastasis to the lung. So after the explanation, the attender they haven't opted for any treatment. That was only symptomatic management, like bronchodilators was given, and also cough suppressants were given to the patient. On examination, she was having the GCS of like 12, around 12, and she was having jaundice. She was deeply icteric. She wasn't like much, her speech wasn't like much clear, and she had like on palpation, she for abdomen, she had like a mass over the upper hypochondrium, sorry. At the emergency department, we gave her the like a significant investigation. On that day, she was having bilirubin of level 13 mg per dl. Sodium was 120 millimolar per liter. CT abdomen finding was like mass forming intrahepatic CCA cholangiocarcinoma, low attenuation, and also she had like interhepatic duct dilation. CT thorax shows ground glass opacities, and focal lesion was there. Then lymph node involvement was also there. She had like bilateral pleural effusion. Atelectasis was there. Consolidations was also there. And the by then the patient was not having, not was she wasn't on any treatment. She was on this over counter drugs for this pain, and after that, coming to the emergency, she was like can you please go to the next slide? The management fund. Okay. Okay. Psychological aspects. As the patient was not well conscious, she wasn't very much oriented and conscious. So we just focused on the primary caregiver, that is her son, and he was like very much worried about her mother's prognosis and health condition. He just like started so like crying in front of everyone, and he just like he was already prepared for that. He know the condition. He had that insight of like her mother's condition, but still he was like weeping around, and we made him calm, and we gave him counseling regarding her condition, and he was like insisting us to put her on ventilator and intubate her, and he told us the history of like she's not eating since so many days, and he wanted us to like insert an RP tube and also put her on ventilator and all. But like we gave him counseling, like nothing is gonna use. Much more things were like spoken to him and the family members, and then the I'll just out the few managements we gave at the emergency department. She was put on oxygen as she had dyspnea. Via face mask, 4 liter was given, and injection tramadol for pain. And also, I missed one thing. We gave her like buprenorphine patch, 5 microgram per hour, and injection tramadol BD. And these things were like we got the history from patient attender. He was like giving the history such. She used to cry because of pain. So the patch was given, and while coming to the emergency, also she complained of pain, and after that she was like getting altered speech. She says something, she cries and moans in pain, but it wasn't so clear. So we haven't like administered any oral opioids, and on the admission we gave her injection Ondum, injection tramadol, and she was given fluids, IV fluids, and vitamin K, and also buprenorphine patch for pain. Main concerns were like dyspnea, pain abdomen, and she was crying on admission, altered consciousness, vomiting, and low oral intake. Summary is like 74 years old female, diagnosis as cholangiocarcinoma with lung metastasis on May 2023, was not on any significant treatment. She gradually developed dyspnea, altered consciousness, vomiting, jaundice, and other symptoms related to jaundice, and decreased oral intake. She like on emergency basis, she was like taken to emergency department where she was like symptomatically managed. She wasn't intubated. She was on oxygen and supportive fluids. And for the caregivers, we explained that she's on poor prognosis. And, also, he also already had the insight of the patient condition and the methods what he had to follow after the patients to be like got discharged at the home was explained to the patient, and also his concerns were also taken into consideration. That is why the patient was his main concern, the patient's attendant main concern was like she is on, like she is having not like she is not tolerating pain when she was like at home. So that is the reason buprenorphine patch was given. The next slide. Discussion points. Like I would like to discuss in this talk, these two topics. Is the hospital admission necessary for this patient?
Hema, read it out.
Is hospital admission necessary for this patient? That is my first point of discussion with everyone.
Okay. Thank you, Hema, for the wonderful presentation. I hope this presentation is clear to everyone. So we will move on to the discussion points. So as Hema is asking, is whether hospital admission is necessary for these patients. We would like to hear from the participants' side first. So please give your opinions. Either you can unmute yourself and talk, or you can put your answers in the chat box. If you have seen these kind of patients, so whether you are willing to send back to their home and manage their breathlessness and other symptoms in their home or not. So the first question is hospital admission is necessary for this patient? So please say something. We all nurses, please unmute yourself and talk, or you can put your answers in the chat box. So on chat, it's difficult to manage in home without a medical person. Okay. Any other answers? Yes, admission is needed. Then yes. Okay, admission is needed. You have to think about the 4 aspects of this patient. You have to think about the total pain of this patient, physical problems, social problems, spiritual problems, and emotional problems. Okay. So Nayana ma'am, over to you.
So, to all those people like who told like she needs admission, let me ask a question back. How long will you admit her? Like her disease is progressing. She is having breathless. Till her end, can we admit her till her death? Because we are not going to treat the patient anymore. So the thing is, We can think in two ways. First is like we have to address her problems. We know that her main concern is dyspnea. She's having pain. So first we have to look into that. How can we manage it? We can manage that in her home also. We can teach her like son or daughter like how to manage this at home. We can give medicines. We can teach them. You have to give it like this. You can do this. We can teach so many things. We can teach the non-pharmacological techniques. We like we learn. We can teach them. Otherwise, we can admit her for some time. We can manage her distress. In a palliative hospital, what we do is we admit such kind of patients who are in severe distress. We admit them. We admit. We we admit them. We optimize the care. We do everything what we can do, and we teach the person who is next to them, and we lead them back to home so that they can be with their family. And if they have any doubts, if they have any concerns, they can address to us, and we reply to that. If she is in hospital, we can manage her pain. What if she go back to home? We can manage her pain there also. We can give advices. So it is not like in such situation we have to keep them in hospital itself. That's what I told. The main concern of these patients will be most of the time it will be oxygen. They will be in oxygen support and they'll be telling that oh, it will be very difficult for that oxygen is not there. But we have to think whether oxygen is helping her. If it is not, even at home also we can give oxygen. We have concentrators which can be kept in homes if it is helping. If not, we have to make we have to make them understand about like why it is not needed, and why it is not helping. It is not helping patient in any way, and we can switch her from hospital to home. Do you have any doubts? Please ask me something. I'll respond. There is nothing like you cannot keep them or can keep. It is according to the patient's difficulties and distress. If they are in hospital, we can manage by giving like IV injections. Later, we'll like convert like all the injections into tablets and we'll teach them everything. That's what we do here. We'll optimize the care and we give a caregiver education.
Yes, ma'am, you are true. You are correct. Because most of the time, in this kind of situation, the patient wants to go home, but the caregivers reluctant because they are not able to much confidence level to manage if they have a distress, this kind of distress in their home. So they are not able to handle it. So that kind of worry is inside the mind all the time. So if you have listened their caregiver side, they will ask many questions. If she developed this kind of touchlessness, what we will do? These kind of questions will be there. So you have to listen their emotions and questions and make them understand these are the ways we can manage even if she is in home. So these all things failed, then you can think about to admit her in the hospital. So these kind of things you have to think about. So I think one more question, Jeba wants to ask something.
Yes, madam. Actually, I saw a lot of patients in the lung cancer patient when they are feeling that breathing difficulty. So psychologically, they want to go to hospital because we can able to give the oxygen either through cylinder or concentrator. We can able to arrange the BiPAP machine also. During the hunting them, psychologically their thought was if the doctor is present, they will do something like that. They will feel. So that's what in my side always I will say that in any lung related disease, better they how to keep any medical center is better. I think so.
Jeba, we understand your that concern, but at the same time, you have to think about the patient sides too. So we have to meet their wish. Even if sometimes they request you to, I want to go home, but the relatives sometimes reluctant, and also we are also worried. Oh, so why? How they can manage at their home? But the patient wish. So we need to We need to meet. No, so at least. So that time, what we do here is we will discuss with the family and make them understand and give some kind of medication. So these all things we will teach the caregivers, and in front of us we will try to manage. So if she has developed this kind of distress, we will in front of us the caregivers will try to manage, so that they will get a confidence level, and after that we will send them back, because as ma'am said earlier, how long you will keep it in hospital? Financial crisis will be there. If they don't have enough money, how will you admit in the hospital in a long period? So that also we need to think. So there are non-pharmacological measures and pharmacological measures, but these all things sometimes the caregivers doesn't know. So these are the ways we don't. Usually they will tell us like, so we were not knowing this. If we know earlier, so we could manage this her in home only. This kind of that questions and emotions comes that they will search to us. They will. So definitely you have to these kinds. Sometimes you have to keep it in the hospital. But if the patient has raised these kind of wish, so definitely you have to think about the patient wish too. Okay, madam, anything you want to add?
There is one more discussion point that what further managements can be explained to the caregivers. So I want to talk about it. Like, it's not like giving all the medicine, sending back them home, and we are just leaving them like that. We'll follow them. Like, we give all medicines. How are they? We have home cares here. Otherwise, we'll ask them to bring the patient to OP, or we'll go and see. We have home care visits. In that visit, we will try to modify our drugs. Like here, the patient is on buprenorphine patch, and she's also on tramadol, but there is no pain relief. So we'll do the necessary steps for pain management. We can start morphine for that patient. Sometimes it might help. The lower dose might not help. We'll increase the dose. We'll add adjuvants. We'll see. It's not like we are going to give definitive, like you have to do this for this. It's not like that. You try. We give. We see how it responds. We change the medication. Like that. That's what. And most of the time, caregivers will be having a lot of doubts, and we'll clear it like slowly. We'll send them home. We'll see them. We'll follow up them, and we give advices. And we'll give our phone numbers. The hospital phone number will be with them. They will call and ask what we have to do. In some situation, some patients who are in end of life situation and all, sometimes they will be at home and they'll call us and ask. So most of the time we'll try to give advices. We'll try some patients who are living very far away and all, they will not be able to bring the patient and all. So we give advices through phone. We try to we try to help them out through phone and all. Like that. That's all.
Hema, your question answered well. Is there any other questions?
No, actually, it was a discussion point. Like every one of us, like every one of the other people might have known better than this. I just want to like discuss at my patient point of view. So, like, may I say add on few words to this story.
Okay.
Yeah, this patient, of course, the hospital admission, according to the patient attendant's point of view, when his mother was getting so dyspneic, they just came to the emergency department, and there she was like symptomatically managed, and after that, he requested to keep his mother at hospital admission, but he was being explained like again and again that this is not necessary, and he was like again requesting for the intubation and ventilation and all, and as I'm from a government medical setup, institution setup, so they weren't ready to like waste resource for the patient who is on the end of life. So it was no from our side, so it is like we explained the patient, like however he know the condition, he wasn't ready to accept to see his mother in such a condition. So the counseling helped in that state. And we asked for his satisfaction, we asked him to like arrange an oxygen concentrator at his home setup, and he took his mother with that. And also we gave her with a like discharged with a buprenorphine patch, and which we advised him to like change once a week, or else if she cries after 3 days or like once a week, it is fine. That was the advice given to her. And SOS medication was like written for vomiting, and also if extreme pain was there, but morphine was not advised, as we weren't able to like discuss with the patient, as she was at altered consciousness, so morphine was not advised. And other than that, keeping her with like daily activities, brushing, bathing, those things were advised to the caregiver. And once the patient got discharged, we called him after 2 days, and he said she was no more. And the patient like on the first day, like after the patient was like compelling us to keep the patient for patient attendant was compelling us to keep the patient for 1 day, we explained him that if at all she passes away in the hospital, that won't be better for her. It is always nice to spend the last hours of the day in the home setup. So that was advised to the patient, and he patient attender, and he took the patient to the house. And one day she was very well, like according to the patient attender, the son told she was like very well with the oxygen. She was coping up fine, and she was seeing and smiling at the faces. And after that, another day morning, she was no more. So that was the thing we got from the attender. So that's all about my patient story. Thank you, everyone.
Okay, thank you, Hema. You did well. We are happy to manage like that. So because this is very, very important, you can able to meet her wish. So we understand that there are lot of questions from the caregiver side. Even then you listen their concerns and explain them well, and make them understand, and you can able to meet her wish. So thank you very much. We all expect from others too. So with this kind of story, so if there is a curative factor there, definitely you have to think about that. But if the prognosis is too bad, and the person is not go back to their normal stage more, then you have to think about the symptomatic management, and try to talk to the patient and the family, and so that we try to manage it, so that the patient and family feels well, and they will remember always from your discussion points, and all things they will remember all the time. So thank you, ma'am. So anyway, anybody have any more questions or comments? So sometimes you might be thinking like you can put so at least put this patient is on ventilator. So you can we all nurses, we all know that even if the patient is on ventilator or suffering. So if there is a curative possibility there, definitely you have to think about that. But otherwise, the patients will be more in distress, no? So, definitely the patients will not be able to come back to their normal position. So better to think like this. If there is a curative possibility there, definitely you have to think about the interventional management like this. But otherwise, you can give a symptomatic management. You have to think about the comfort of the patient all the times and make them comfortable as much as you can. Okay, I think no more questions. Madam, do you want to add anything, any points?
No,
So
sister.
otherwise, we can move. We can.
Thank you.
No.
Thank you so much. Nothing.
So, okay, so thank you, Dr. Nayana, for the wonderful presentation, and also thank you, Sister Hema, for the wonderful patient story. We all hear the good side and bad side of the patients. Anyway, the patient story is a big loss for their family, but at the same time, they are able to so give a comfort and that they can able to meet her wish too. So thank you very much for the wonderful presentation, and thank you all others for the participation and your contribution. Thank you.
Thank you, Dr. Nayana. Thank you, Shiva ma'am, and all the participants. This is Anup signing off from TIP Sarco Hub. Bye. See you.